Thank you very much, and I'd like to thank the Society for allowing me to present. I also want to acknowledge all my co-investigators who are on this slide. Many of them are in the audience, and many of them are ICS members. This was an RCT, and the name of the study was Gladiolus, which is Group Learning Achieves Decreased Incidence of Lower Urinary Tract Symptoms. Those are my disclosures. The aim of this project was to compare the effectiveness of a novel group-administered group behavioral treatment program, GBT is how I refer to it, to no treatment in older adult women with stress, urgency, or mixed urinary incontinence in a multi-center setting. We had 3 sites. This was a multi-site prospective randomized controlled trial. How we got these women was we did mass mailing recruitment letters that we have described in other studies. We sent them to women over the age of 55 or 55, and we do that per zip code, and it was done in Alabama, Michigan, and Pennsylvania. We were seeking treatment-naive women, so they could not have previous drug therapy or previous surgical intervention. We initially screened them at one site by phone. And at the actual site, we also pre-screened them to make sure they had never received treatment and they did not have any exclusion criteria. Those were our research sites. We did baseline screening, and then they were randomized. The inclusion-exclusion criteria was ambulatory women greater than or equal to 55 years or older, stress, urgency, mixed UI for 3 months or more, no symptomatic POP, and we did do physical exams, pelvic cancers, bladder surgery, bladder cancers, no neurologic problems or diseases, no prior OAB or UI medications, no prior treatment. And our primary outcome was the ICIQ UI short form, but what we did for pre-screening is that they had to have at least a score of 3 or above to be included in the study. This was the 2 arms. The GBT teaching protocol was a 2-hour face-to-face group session held at the sites, individual sites. The information was similar to what you just heard: anatomy and physiology of the continence, pelvic floor muscle identification training with NAC stress strategies, bladder training, urge suppression strategies, and then we gave them a brochure of a write-up of some of these strategies. The control group got nothing but the brochure. At the end of the study, they were asked if they wanted to go back into the class, and most of them did come to the class that we held at the end for that control group. Outcome measures was primary ICIQ, UI short form. Secondary was we had these women do a 3-day voiding diary. We didn't see them if they didn't have their diary in hand. 24-hour pad weighing, provocative cough stress test or pad test, PGI-1, IQ qual, MESA qual, bring pelvic floor muscle strength test. The evaluator who did the pelvic exam and checked the pelvic floor muscle strength was blinded to the participant's assignment. Timeline was baseline 3 months, 6 months, 9 months, and 12 months. We randomized 463 women, and you can see they were split between the intervention and the control. Only 7.3% withdrew in that time period. Demographics, there was no differences between age, race, education, income, living with a partner, BMI, medical, and surgical histories. The outcomes, at baseline, there was no significant differences between the measures between the 2 groups, either in the primary or secondary outcomes. At 3, 6, 9, and 12-month follow-up, there were significant differences in both primary and secondary outcomes favoring the group behavioral treatment arm, except there was no increase in the Brink pelvic floor muscle strength in either group. When we look at secondary outcomes, there was significant improvement in favor of the intervention over control in all time points, 3, 6, 9, and 12 months. Percentage of leaks on a 3-day voiding diary, 24-hour pad weight test, provocative stress test, MESA questionnaire score, incontinence qual, and the patient global impression of improvement. And I'll show you some of this data. So for the ICIQ UI short form, you can see the second column there is a total of all subjects. Third column is a group intervention, and then the control group. And as you can see, we had consistently drop in the ICIQ all the way for the control group, consistent down to 12 months, of which 9 and 12 was significantly different. In the control group, there really was no change. When you look at the average number of daily incontinence episodes from the voiding diary, again, you see the same pattern. Here's the behavioral group, the control group, and again, you see a definite drop in the group training as opposed no change in the control group. And then when you look at the patient global impression of improvement, respondents were significantly stated that they were improved much better. And as you can see at 3 and 12 months. By the way, to anticipate questions, we did adherence, and we have all that data, we just don't do it. And the new data that we do have that will be published did decrease costs. We did look at costs of these two groups, and the costs did decrease as far as pad use and others in the intervention group, and that will be reported later. So the conclusion is this novel group behavioral treatment bladder health education program was effective in reducing UI frequency, severity, and bother, in improving quality of life in older adult women in the community, for all levels of UI severity per ICIQ, UISF at baseline, regardless of the lack of no change in the pelvic floor muscle strength per the Brink scale. This easily scaled intervention increases the opportunity to reach larger populations. We also did check for cognition. I don't have that data here, but we did do the clock drawing test to exclude individuals who were based on any type of memory issue. And we also did a get up and go test to make sure that they were functional. Thank you very much.
Okay, the floor is now open for question. Gary?
Oslo, Norway. I would really like to congratulate you with a fantastic study. This was very well conducted, high methodological quality, and also you described the intervention very well. So congratulations.
Thank you, Carrie.
Can you just tell what was the average age of the participants?
In their 70s. In their 70s, yes.
Yeah,
and
yeah.
we actually were trying to get older, but that's about in the 70s.
Okay, okay. And then I just wanted to comment on the pelvic floor muscle strength, because you were doing the NAC, and we have already shown that the NAC is not increasing the strength, but it's a very good behavioral thing to do to prevent leakage. So I think that explains what happened, because they were doing the NAC, and that's effective by itself.
Well, no, but they also were given a CD that walked them through an exercise session. So it was not just the NAC. They were actually taught pelvic floor muscle exercises in the class. We did not do it through the pelvic exam, you're right. So it wasn't with really, hands-on digital, say, feedback.
No.
But we also then gave them a CD that actually told them, okay, now squeeze, and it walked them through an exercise. It was about a 5-minute CD, the intervention gets. So, we did, work on that. So it was really a good behavioral treatment program as an education program, though, okay? Nothing else as far as, biofeedback or anything.
But I just think that the studies that have shown that there is an increase in strength, they have followed very intensively the strength training, so.
No, I know. I mean, we were kind of surprised the Brink didn't change at all. I hear you. I mean, and by the way, these women underwent pelvic examinations for those visits, at least 4. Our retention rate was significant. We thought we'd have dropout. We did not. I agree that, it was all nurse practitioners who did the pelvic examination, so they were all trained. Yes.
Jean Haysmith, New Zealand. Diane, thank you for a methodologically robust study and beautifully reported in terms of the methods and the intervention. The question I have is that I could see that the differences between groups were highly statistically significant, and that's certainly very interesting. I'm wondering if you can give me some indication of the actual magnitude of the difference in terms of the actual sort of mean differences or median differences in terms of the actual score. I'm trying to get a sense of what the actual difference might be between the groups and the confidence interval for those differences in terms of magnitude of effect.
Well, we haven't really looked at that yet. We really just broke this a couple months ago, and I know, and so it's the initial data. We have a lot of data on these women. You can see there's a large number of women here. Yeah. And we want to look at specifically what's gone on with the pelvic floor, but also with the pad volume and all that. So there's a lot of stuff I can't really report now. I thank all of you for your comments, but I want to just tell you that this was a combination of a lot of researchers in this area, Kathy Bergio, Patty Good, Carolyn Samsel, so we're very proud. This was supported by the National Institutes of Health, the National Center for Nursing Research. Thank you. I think that's all.